Good morning, and welcome to today's webcast, Opportunities for Value-Based Care, the Direct Contracting Model. Before we begin, I'm going to play a brief housekeeping video.
Welcome, and thanks for joining us. We're pleased to present another in our ongoing series of continuing professional education webcasts to help companies and individuals conquer challenges as they plan for what's next. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize how you both view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement or enter full screen mode using the controls at the top of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. You can download the group attendance sheet and a PDF copy of today's slides from the slide deck and handouts widget to the right of the slide view. You can ask our presenter questions during the webcast by typing a question in the Q&A window below the slide view and clicking Submit. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key. Today's session will offer you 1 CPE credit. To receive credit, you must meet the requirements as specified by the National Association of State Boards of Accountancy. You must attend at least 50 minutes of the session and respond to at least 75% of the polling questions, which we'll ask throughout today's presentation. To respond to a poll, click the button next to your answer. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget to open a PDF file that you can save to your computer. Don't worry if you can't download your PDF certificate today. We'll email a copy to you in 2 weeks. If you're attending this webcast in a group, you must complete our attendance sheet to receive CPE credit. The attendance sheet is available in the slide deck and handouts widget. Please have all group members sign it and send only 1 sheet per group. Also note that CPE credit can be awarded only to participants registered as themselves and isn't available to participants who view the on-demand version. As a reminder, the presentation you're about to see isn't legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
I'm pleased to introduce today's presenter from Los Adams, Georgia Green, Manager, Strategy and Integration. Georgia has worked in the healthcare industry since 2011. She provides strategic and operational consulting services to healthcare providers and payers and has extensive experience in helping clients integrate value-based care models, such as accountable care organizations. She guides clients through the process of value-based care transitions from start to finish, including strategic analysis, program design, budgeting, contracting, waiver development, training, compliance, reporting, and performance improvement. Georgia also has experience in developing population health revenue optimization programs. She has worked strategically with many community health organizations to assist them in overcoming their unique challenges and capitalizing on advantages. And before I turn it over to Georgia, I did want to mention that we are all working remotely, and Georgia is actually working off of a generator, so please bear with us today in the event of any technical difficulties. And with that, I will turn it over to Georgia to get us started.
Thank you so much, Emily. I appreciate the introduction. And welcome to the webinar, everybody. I appreciate you being here on this St. Patrick's Day in very interesting times, very memorable times, I think, for all of us, and important. So I'm glad to be here connecting with you all to the extent that we can connect. We'll do it here online. Please do feel free to put your questions in the chat box, and if I don't have time to get to them here on the webinar, I will definitely follow up with you via email, probably within 24 hours with an answer. So yeah, feel free to reach out that way. So our agenda for today is on the screen. I always like to provide a little bit of context about what this transition to value-based care is that's leading us to have this direct contracting model. And then we, of course, will go through the model and many details about it, the different entities involved, their roles and functions. There are a lot of options in this model, so we'll go through that. Eligibility, of course, probably many folks on the call might already be participating in CMMI models or Medicare models. And so, how do these programs interact and overlap? Very important. And then some of the rules around beneficiary alignment, who gets attributed to your not ACO, but your DCE, and enhancements that come with the model, or benefits that you might get from being in the model. The financial model elements, quality reporting, and I have quite a few slides about strategic considerations. And it's still early on, so I would say I just want to give a caveat that Medicare, there's still emerging information about this model. They've done quite a few webinars and office hours, but a lot of the detailed financial sort of benchmarking process and risk adjustment process and adjustment factors have not been specified by CMS yet. So we are on standby for that information this summer. So this is the information we have to date. I'll just say that. So I like to start with, just a little context that, Seema Verma, the CMS administrator, is, very much on board and in alignment with, everything since the Affordable Care Act that is moving our Medicare program from fee-for-service toward fee-for-value. And the idea being that value is providing high quality at a low cost. So in reporting on quality, being evaluated on the cost of your patients and your care that you provide, these are kind of fundamental metrics that feed into value-based care models. And that we see across the different types of models. And this is not meant to be all-encompassing, but you can think about models in a few different buckets. So what we've seen in the past is accountable care organizations, and the Medicare Shared Savings Program is a very popular program. I think there's over, close to 600, certainly over 500 Medicare ACOs in the country. And this is, groups of providers becoming accountable for the total cost and quality of care for their population. We've seen bundled payment models. These are becoming responsible when you become responsible for a bundle of services, usually following an event such as a surgery. And then geographic models where providers become accountable for patients across a defined geography, such as a whole state. And each model is designed a little bit differently. They have different carrots and sticks. And, I would say that there's just a general transition from, early adopters received more carrots and less sticks. And as we, go along down our timeline here, Medicare is starting to make these models more mandatory instead of risk-based models being optional, where, your payments are being put at risk that you might owe money back to Medicare if your costs go up. Those are becoming more mandatory, like a forced transition toward that. And of course, we're now moving into this frozen physician fee schedule time period. So, it's providing more incentives to get in, I suppose, sooner than later. I'm personally of the belief that it's important to prepare because these aren't going anywhere. They've stayed with us across different political administrations. They have bipartisan support. It'll be hard-pressed to find someone who doesn't think we should be making Medicare and healthcare costs go down and quality go up. It's a pretty agreeable goal. So the direct contracting model is just the latest in the series of models that CMMI, the Center for Medicare and Medicaid Innovation, has put out. And it's a set of 3 new voluntary payment models, again, aimed at reducing cost, enhancing quality, and it's based on total cost of care or primary care capitation. And so we'll get into the details about that later. But basically, if I was to summarize it in a few sentences, I would say that Medicare is testing and hoping that by providing predictable, prospective monthly payments to these model participants, that they will use these funds and the stability to invest in population health management tools, care management, targeting patients with multiple chronic diseases, that kind of care management work to reduce those patients' total cost of care and the average patient's total cost of care and provide new benefits and new incentives to their providers. New benefits for beneficiaries, new incentives to providers, I should say. So just, really snapshot fast facts is that it's a 5-year model. So it was the first cohort really starts in program year 2021. But there is this implementation period that is basically for the remainder of calendar year 2020. And the application for that was already due in February. So if you didn't submit that, too late for the implementation period, but the application is still open for starting in year 1. And the implementation period, I would say, is not such a dire thing if you have missed that, because it's really for organizations who do not have experience working with Medicare patients to start getting alignment of patients through voluntary alignment. So we'll talk about that. So they did release the date. So the due date for the application is May 1st. And I'm not saying that there won't be, but CMS has not announced any later application rounds, meaning, they have said that this model starts in 2021, it goes for 5 years, so through 2025, and that they have not said, and there will be a cohort that starts in 2022 or 23. We're going to have to wait a year to find out about that, or at least, till the end of this year. So, yeah, so it might be a one-time only opportunity. It does qualify as an advanced alternative payment model. So, for those of you who know a bit about MIPS and the Quality Payment Program, by being in this model, which, given the level of risk it has and IT requirements, et cetera, the participants in this model receive the automatic positive 5% MIPS adjustment, rather than being in that pool where, for example, last year, the maximum score was 1.68%. So that's a pretty sizable benefit that adjusts your Part B payments. So let's talk about different entities and roles. There is the key entity here is the Direct Contracting Entity, or DCE. And this is a lot like an ACO. It's an umbrella entity. It's the convener. So the DCE contracts with Medicare, and it contracts with the providers. So it's that umbrella, between the sky and the person holding the umbrella, the providers under the umbrella. And its key function is to receive payments from Medicare and distribute them to providers. So in this model, the DCE becomes kind of like a MAC entity. And then there are participant providers and preferred providers. And these are both defined at the TIN NPI level. So you don't have to include an entire TIN in the program. You can select which providers within a hospital or clinic would be in or not be in the model. And the difference between participants and preferred is that if you're a participant, they are using that NPI to determine which beneficiaries are aligned. That person must be paid via this DCE capitation, by the DCE via capitation through the model. So that provider is no longer getting money from Medicare. They continue to submit their claims as they normally would, but what Medicare says is it's subject to 100% claim reduction, so they don't get paid by Medicare. And then the preferred providers have sort of an option around that. So they could receive their payments through the DCE, or they can decide a portion of their payments that'll get paid by the DCE. So, maybe half of 50%. So they get 50% fee-for-service claims, 50% from their DCE. Okay, so that's our types of providers in the model. There are also 3 different types of DCEs, and I think the standard DCE is what would apply to most applicants and probably most people on this call. But just for the sake of understanding, the standard DCE is for entities that have substantial experience serving Medicare fee-for-service beneficiaries. And basically, it's just saying Medicare can look back at your claims history and be able to align patients to your DCE. There's also new entrant DCEs. So something Medicare's kind of jazzed on is that they will be able to include medical providers who are not necessarily Medicare providers in this model if they're new to Medicare and want to participate. And then there are also high needs population DCEs, and that could be kind of like a PACE program or folks who are working with, disabled or, multiple chronic disease patients exclusively. So again, I touched on this, but the DCE's core function is to receive monthly payments from Medicare and process the claims data that they're receiving and distribute payments to their providers that are their participant providers and preferred providers. But, operationally and functionally, a DCE has flexibility in how they do this, but they need to provide services that are going to deliver value-based care. So that could include the care coordination program, IT infrastructure, data and analytics services, and depending on the population and the needs of, just your community, whatever strategic programs and initiatives might help reduce costs, help promote quality in your population. So there are also 3 different payment model options, but only the first 2 are available right now. So there's the professional and the global. The geographic one is CMS has mentioned it, but they have not actually rolled it out as an opportunity to participate in that yet. So I suppose in future years, if they do continue to expand this model. The professional option is a lower risk model. It's you're liable for 50% of shared savings or losses, and you would receive primary care capitation equal to 7% of the total cost of care benchmark. And we'll take a look at that in a moment. But the basic working theory is that your current primary care services are probably 2 to 3% of a patient's total cost of care. That's, looking at an average. And so that the 7% payment you receive is an enhancement on top of that Medicare is providing. The global model is a full risk model. So you're liable at 100% of shared savings or losses as compared to your benchmark. And there are 2 options for either the primary care capitation or total care capitation. So I'll hand it over to Emily for our first polling question.
All right, our first poll for today: which type of DCE is possible for your organization? And your options are A, standard DCE, we have experience with FFS Medicare. B, new entrant DCE, we are new to FFS Medicare, for example, Medicaid managed healthcare plans. C, high needs DCE, we participate in the PACE program. Or D, not applicable, or I'm not sure. And I'll give everyone a few moments to respond. To participate in our polls today, please click the button next to the answer you choose and hit submit. I'll give you a few more seconds here. And let's go ahead and take a look at the results. Georgia, back to you.
Okay, thanks so much. Well, I think I was right in my suspicion that there are probably a lot more standard DCEs on this webinar and out there in the world than the other types. But I'm definitely interested to follow up with some of you who might be in the other types and take a look at this, because it's a little more complicated as you're evaluating the opportunity. So we'll keep going. Emily, would you please advance it to the next slide for me?
Yep, we're on slide 15.
Okay. All right, thank you. Mine was just loading slowly. Okay, and I apologize. Just like Emily mentioned before, I'm about waist deep in snow with no power. So we are just pioneering it today in the woods of Northern California. Okay, well, anyway, at least it's a wonderful distraction. Very pretty outside. So let's take a look here. So participant eligibility and program overlap, important issues to think about if you're getting into this model. So any provider, it's a lot like the Medicare Shared Savings Program, can only participate in one DCE at a time. There are certainly a lot of requirements related to governance and the board, and the application kind of has many questions that covers this in detail, but something I want to highlight is that the DCE's governing body has to have over 25% control held by participant provider representatives. So they want the provider voice at the governance level. And then you have to reach a minimum number of aligned beneficiaries each year. And my next slide has that detail for you. So if you're using this slide as a resource later, you'll be able to access that. Program overlap. It's worth noting that they did say that NextGen ACO, MSSP, and other Innovation Center model participants can apply to this model. However, the MSSP overlap is only allowed this year in 2020. So if you are in a Medicare ACO and are thinking of transitioning to this model, just keep in mind that you'll have to remove yourself from your ACO or terminate, if you're an entire ACO, terminate your participation agreement by the end of this year, 2020, in order to participate in 2021 in DC. And then overlap similarly with CPC Plus or Primary Care First is not allowed, but overlap with the bundles programs such as BPCI-A is allowed. So it's kind of a decision point of, okay, we know we want to move in this direction, but which model is the best for us? And that's one of the services I help clinics and health systems think through and analyze on a strategic and financial level is, how do these different models work, and what are the potential outcomes and, scenarios that might arise from being in each one. So you can see this table has the minimum number of aligned beneficiaries. So the standard DCE is just like the Medicare ACO. It requires 5,000 minimum at the start of each year. The new entrant one and the high needs one have kind of an accelerating number of beneficiaries each year because they're allowing time to ramp up the program. So beneficiary alignment, I apologize, the print is small on this, but these slides really are meant to be a resource to you all to, dig into this later if you want to. I guess what I just want to highlight here is that this model really expands upon voluntary alignment. So claim-based alignment is much like a Medicare ACO in that Medicare will look at providers' historic billing and for any given patient, where did they have the plurality of their care, of their primary care services? And plurality is Medicare's fancy way of saying the most dollars spent. So if patients have the most dollars spent with your DCE providers, then they will get attributed or aligned to your DCE. And if they have been receiving care from other providers outside of your umbrella, then they potentially may not get attributed to you. Just depends on the number, the amount of paid claims. But there's also a really expanded voluntary alignment program with this model. So currently, any patient can log on to mymedicare.gov and select their primary care provider. Very few people do this. This is not something that, I work with an ACO that's got like 16,000 lives or so, and they have, a handful, less than 10 patients that have done that. So it is not a common thing to do. But in this model, they allow paper-based voluntary alignment. So if you're in the model, could potentially send out a form in the mail to everyone in your service area, which is your county and the contiguous touching counties, and try to sort of manually collect patients into the model that way. And what is interesting too is that the voluntary alignment supersedes the claims-based alignment. So basically Medicare is saying that the providers, that the patient's priority, whatever they express, takes priority. There's also this prospective alignment versus prospective plus alignment. And basically prospective alignment just is kind of a single point snapshot where Medicare says, here are your patients at the beginning of the year. And that makes it very clear as to what your benchmark number is. At Prospective Plus, they update it quarterly, and so that allows potentially an increasing number of patients as you get, new patients or new to Medicare patients. But it also makes your benchmark, less predictable, more variable. So this slide, I'm not going to read each and every one of these, but it's a list of the proposed benefit enhancements in the model, and this is just one of those areas where Medicare hasn't completely fleshed out. These are the enhancements. They're still considering that. Maybe, I don't know if they're still looking at comment on that, but I'm sure some of the big lobbying and political organizations are commenting on it. So these potentially are items that when they're finalized, your organization would really want to consider carefully, are these things that we can capitalize on and use to our advantage. So the benchmarking. So the benchmark is that per beneficiary per month payment that you receive from CMS. And it is set each year, and it is really reliant on looking at the past cost of your patients for Part A and B services. So Part D is not included in this. And you can see there's kind of this, with the arrows here at the bottom, stepwise thing. It's not exactly a stepwise process like this. Some things kind of happen concurrently as they're doing this calculation. But essentially the benchmark sets that capitation amount that you receive, either the primary care or the total cost of care capitation. So they're looking at the historical spending for the 2017, 18, and 19, and those are weighted 10, 30, and 60% respectively. And those benchmark years always stay the same through the whole program. So that is the benchmark period for this program for the 5 years. They trend it forward based on, per capita growth, cost growth. They use a Medicare Advantage rate book to adjust it so that, does some regional adjustment. They also take into account risk, and that means your HCC scores of your patients. So in this model, as in every other model, every other value-based care model that I've seen coming out of Medicare, it is certainly advantageous to get good at coding and submit those codes on claims and get the HCC scores as accurate and specific as you possibly can. That is a worthwhile initiative, whether you do this model or not. So there is also a 2 to 5% discount if you're in the global option. So essentially, whatever Medicare comes up with as that benchmark cost, they're going to knock off 2% and say, okay, this is your target. You need to reduce your cost by 2% in order to achieve shared savings in this model. And that 2 to 5% increases gradually each year in the program. And then also Medicare withholds 5% in a quality performance risk pool. So that you can earn back that 5%. You actually can earn back more than 5% if you're a top performer in the program. So looking at, the most important part of this model is that it is a capitation model. This is a mandatory part of the model. And so these payments are not reconciled against any actual claims expenditures, even though you are continuing to submit your claims. So the total care capitation is just looking at that benchmark we just talked about, and then they take out what they estimate to be kind of a leakage percentage. So, okay, the patient's total cost of care per month is $1,000, but we think you're only providing, you, the DCE, are only providing 60% of that, so you get $600. And then the primary care capitation looks at your primary care portion of the total cost of care and adds an enhanced portion to get it up to 7%. So that's always going to be 7% of the total cost of care. So if your primary care makes up 2%, that enhanced portion is 5%. If your primary care makes up 3%, that enhanced portion is 4%. But please note that that enhanced portion is a, well, I'll get to it, but it is a payment mechanism that is just a cash flow mechanism. They do recoup that enhanced part of the 7% in their final calculation. And then I have kind of a glossary of some terms from this model that you might hear and are good concepts to understand. So there is another cash flow mechanism that is the advanced payment. So if you're doing just that primary care capitation, you actually can receive an advanced payment that kind of levels you up to the total cost of care payment, but it's, again, recouped at the end. So it is just a cash flow mechanism. It's not for keeps necessarily. Again, as I mentioned, risk adjustment, the methodology has not been provided yet, but it definitely will be part of the model. They also have mentioned that they will have a stop loss arrangement. So for those of you who are in the Medicare Shared Savings Program, you're probably familiar with the idea of truncation at the 99th percentile. And that's just, one of the benefits of that model, you just get that. In the DC model, it is actually going to be something that the DCE pays for. And so it's kind of like buying insurance, buying car insurance. You're basically paying to get stability and addressing those random high cost patients. And then they have also created this provisional financial reconciliation option. Again, this is an option, probably something that the DCE will have to pay for, but it just provides more timely distribution of your shared savings or potentially your shared losses, so that it happens in January following the program year instead of waiting, till June or July or, whenever Medicare gets to it later in the year. So, yeah, that's kind of an interesting thing. And, I think a response to provider demand saying, or at least in the Medicare Shared Savings Program, the payment, you're usually waiting until September of the year following that you earned it. So that's a big lag in payments. And there's also risk bands in this model. So as I mentioned before, in the professional level, you'd get 50% of shared savings or losses, and global you'd get 100. But there actually is kind of a gradation to that. So I don't have the table in this slide deck, but essentially if you have a large amount of shared savings or shared losses, that number tapers off. So for the professional option, for example, for 1 to 5% of shared savings, you would get 50% of that for the first 1 to 5% that you earn. But above that, it would start tapering off, down to 2.5%, for example, when you get to 6% shared savings. So just a quick summary, you can see professional versus global options. Just a little summary of what we've talked about already. And I just want to, highlight again that 7% primary care capitation, the enhanced part of that is a cash flow mechanism, and not truly an enhanced payment, in my opinion. And this visual might help you understand it. This comes straight from Medicare's slide deck, so I won't take credit for it, but I do think it's useful. So you can see, Medicare has gone through that whole stepwise process to come up with this benchmark payment of $1,000 per beneficiary per month. And then let's say at the end of the year, the organization has gotten $530 in their capitation and advance payments and reduced fee-for-service claims payments down to $410. So what they've done is they've saved Medicare $60 per patient per month. So that's that gross savings you see. And, you know, this is a hypothetical example. We don't know exactly what they did, but they managed to maybe bring patients in network and provide this care coordination service or use generic, you know, instead of brand name drugs. And they reduced the overall fee-for-service claims payment. And so they saved $60. That gets distributed to them because they're in this professional model. You can see these corridors or the risk bands I was just talking about. So they're getting 50% of that first 5%, and they're getting 35% of the next 5 to 10%. So that ends up being $28.50 per beneficiary per month of shared savings that they earn. And I apologize if I'm moving fast through this, but I want to keep us going. So I'll hand it over to Emily for our next question.
All right, thank you. Our next polling question, what DC model benefit is most intriguing to you or your organization? And your options are A, predictive prospective monthly payment, B, voluntary alignment of beneficiaries, C, benefit enhancements and waivers, D, provisional financial reconciliation, or E, not applicable or I'm not sure. And as a reminder, if you would like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. We're on our second question. And just a couple more seconds. All right, let's go ahead and take a look at the results. Back to you.
Okay, thank you. Yeah, I think that makes sense to me that people are most interested in that predictable prospective monthly payment. I think that's, you know, Medicare understands that and that's why they're offering it. So let's get into the quality piece of this. So it's definitely a bit more complex than what I've provided in this webinar to get into, you know, all the details, but I wanted to share what the the DCE quality measures are. There's a CAP survey, there's the advanced care plan, which is, you know, end of life planning, and then there's admissions for patients with multiple chronic conditions and all condition readmissions. And these are all, you know, claims-based measures or potentially the advanced care plan on the registry measure. And the ACO CAPS is performed by a vendor. They also are, you know, suggesting some test measures as well, gains in patient activation measure scores at 12 months and days spent at home for the higher risk, the DCEs that have highest risk patients with a score over 2. So that's probably like that high needs population. And then, as I mentioned before, there is a 5% quality withhold that can be earned back, and that's just based on your performance on these measures that I just mentioned, plus meeting certain thresholds that have to do with continuous improvement or sustained exceptional performance. So as long as you're doing that, you'll be able to earn back your 5%. However, if you don't earn back the full 5%, that remainder, so maybe you earned 4%, there's 1% left over, all those remainders from all the participants gets put into a high performer pool. So I suppose it gets left in the kitty. And then the highest performers who do meet their standard would earn back that pool. So they even have the potential to earn more than the 5% withhold. So transitioning to think about the application, there was a required letter of intent, which was just a web form, you know, filling out your information on the web that was due in December. However, it is interesting to note that Medicare acknowledges that now that they've released kind of more information about how the model works, that some organizations would need to let's say, form a new LLC to be the DCE entity that wouldn't have even existed in December. And so if you applied to this model, maybe using an individual practice or a clinic, but you're thinking, gosh, I can't do the model because that's not the DCE entity, then, you know, the door is still open, because basically what Medicare is saying is you can initiate the online application using that tax ID number that you have, that you applied with, that you sent the LOI with. But then you can change the DCE's TIN and legal business name. And so this kind of opens the door for maybe some horse trading, I suppose, if you know someone who submitted an LOI and might give it to you to keep the door open for you, or if you simply just started it with an organization that you think is not really the appropriate entity to be your DCE. There are 2 application timeframes. And so I mentioned already that the implementation period 1 is closed, and the second one is now from March 31st to May 1st. So May 1st is the deadline to apply for program year 1. They'll announce the awards in August. The provider list needs to be finalized by late September. And they'll provide some preliminary information about the benchmark and beneficiary alignment, but that would also be released and kind of finalized in December. And then the participation agreement with Medicare committing to being in the program would also need to be signed in December. And they are being thoughtful about, you know, that some organizations might be concurrently applying to the Medicare Shared Savings Program and this model. And so they have released kind of a side-by-side timeline, making it clear that, you know, you can apply to both, you can make your decision, but I believe it's end of October that you would need to kind of have that decision made. And you can see down here kind of their assessment criteria. There is, in my opinion, a lot in this application, a lot of narratives, a lot of kind of fleshing out who and how before you can even really apply. So, you know, if this is something you're considering doing, don't wait till April 30th to start your application. I would say you should probably be well underway with modeling it out and talking with your leadership team. Or talking with me. So let's talk about some strategic considerations. So I tend to think in terms of pros and cons. That prospective predictable PBPM payment that you said you're interested in, that is definitely a big pro. I also think the advanced APM status, at least for these first couple years, is a big pro. We don't know what the benefit of that will be in 2023 and beyond, but you know, I think we will find out, and I think there still will be a financial benefit to being in an advanced APM because Medicare wants to incentivize everyone to go in this direction. And it's an opportunity to strengthen your network alignment and become the payer, even for your non-employed providers. There's also that list of, there's the potential to, you will receive the complete claims data files. I believe it's the exact same files as the Medicare Shared Savings Program. So if you have that infrastructure in place, you can continue to use that and get that data, those CCLF files. There's the list of benefit enhancements that, you know, are waivers and potentially interesting, although it's not finalized yet, but it might give you some competitive advantages. I think this seems like a reduced quality reporting burden since they're caps and claims-based measures, and I've done a lot of manual abstraction of clinical quality data for MIPS reporting and ACO reporting, and this would be a lot easier than that. And then, you know, this ability to attribute lives via that paper-based voluntary alignment is also novel and pretty cool. Some cons. So, as I've mentioned, the documentation just continues as you've been doing, submitting claims. So it doesn't reduce that effort that, you know, is currently underway. So it's nothing new, but it's also no effort saved. Also, you know, for those in the Medicare Shared Savings Program, you're probably used to the minimum savings rate and minimum loss rate, MSR or MLR, and that's kind of like some guardrails protecting you. So in this program, the shared savings and losses start at the first dollar difference from the benchmark. So if you're above your benchmark or you're below your benchmark, that is, you know, going to determine if you have savings or losses. Also, in the global option, there's this discount that comes off the benchmark that increases each year. So that effectively makes it actually harder to achieve shared savings and losses, because they're looking at your historical cost of your patients and then taking 2% off of that and saying you need to beat that 2% in order to get shared savings. So that seems hard to me. And then competition, you know, something to think about is, you know, what does your marketplace look like? Are there other health systems or networks in your market that might be doing the model, might be receiving these benefits and advantages, might be diverting your patients? And just, you know, that it adds a new element of possibility or uncertainty there. And also, we don't know if this is a one-time opportunity or will be kind of a rolling program like the Medicare Shared Savings Program. So that's kind of an unknown. But you could apply now and then wait till later in the year and say if it's going to, and see what Medicare says about that. So other strategic considerations, just thinking about, you know, how you are going to distribute these claims payments you're receiving from Medicare. Unless you're operating a Medicare Advantage plan right now, you might not have experience, you know, distributing claims payments. So I personally think it might be simpler to just start with your employed providers and then over time in future years add other providers to your provider list that are independent. Other things to consider is, you know, your program overlap or alternatives. So, you know, to me, this model is intended to be for more mature with value-based care organizations, maybe folks who have been in the MSSP or next-gen ACO previously and have experience with risk. You might consider that there are other alternatives for next year, such as Primary Care First, if you're in one of those states, or the Medicare Shared Savings Program that might be a more appropriate place to get the data, get your footing, get your programs established about, you know, how you're going to deliver this kind of care, because it is a transformation. I know that word is totally cliche, but it's accurate. Also, something to think about if you're doing financial modeling around this is what would be the impacts from your prior participation, for example, in an ACO. What have you been doing in those benchmark years? I mentioned, you know, this idea of competition for patient lives. So how can you do your best to get voluntary alignment in your region? And also just what is the market opportunity and geography of where you can have the best impact without, you know, impact in reducing total cost of care without self-cannibalizing your own services, because that's definitely not the idea here. The idea would be to increase and enhance your primary care services and your preventive services and your relationship with your patients and that alignment you have, and reduce leakage and outside payments that, you know, are going to lower value providers. So, you know, just thinking about maybe if you're in a very rural market where there are no other options, that it might not be an appropriate model for you. And other, you know, self-inquiry questions, you know, just thinking about what is the value of this prospective enhanced cash flow mechanism to your organization, and what investments such as staff, IT, training, compliance. There's a lot of requirements that come with the program. So what would be required to expand your current capabilities, become the payer, provide care management? Can you capitalize on that list of enhancements and waivers? And really, what level of risk are you ultimately comfortable with? And if the answer is none, then this is not the program for you. And if the answer is, well, a little and maybe one day, maybe you start with the Medicare Shared Savings Program. So I'll hand it over to Emily.
All right, our third polling question: which of the following strategic considerations is most important to your organization? And your options are A, competition. We are concerned about our competitors participating. B, model overlap and alternative options. C, developing capacity and infrastructure to meet model requirements and succeed. Or D, not applicable or I'm not sure. And for those of you that would like a copy of today's slide deck, you can download them now from the folder that says slide deck and handouts to the right of the slide view. We will also be sending the slides via email after the webcast. We do have one more polling question coming up, so thank you for bearing with us. And let's go ahead and take a look at the results. Back to you.
Thanks so much. Yeah, that makes sense to me that, developing that capacity and infrastructure is a big task. And I do have experience doing program design and development for ACOs because, each ACO and each DCE in this model is different. And you really need to create programs that are tailored to and based on your existing resources and your geography and your market. So, I think you can't use a cookie cutter approach where someone just tells you this is what you do and you just do it. You got to think about your organization. Emily, don't worry, I'm just jumping ahead to this slide for a moment. So I just want to share with the audience, that this model is complex and it's new. So you're not going to meet anyone who can tell you, oh, I've been doing this model for years and I know exactly what I'm doing. That's just not true. And there are a lot of options in the model. So it can feel very onerous to apply, even if it's something that would be appropriate for your organization. So I just wanted to mention that I'm here to help you. I do have a lot of experience in the Medicare Shared Savings Program, and something that organizations often ask and wonder about is, does this model make sense for our organization financially and strategically and operationally? And that's what we can help you look at. We can help with making the budgets and financial planning, your legal contracts, vendor selection if you're going to, use support from outside your organization, that kind of core question of do we build it or do we buy it? And also just holding your hand and helping you get through the application process and serving as a liaison to CMS if there are questions, monitoring any kind of program announcements and updates, compliance, providing training to your staff. And, these are all things that would be very hard to kind of start from scratch, but we can support you in filling in whatever gaps there might be in your team and kind of completing your needs. So I also want to wrap up with some closing thoughts that, obviously this is a somewhat ironic time to be talking about this model because we're talking about long-range planning. This is a long-term, 5-year model, and this is part of Medicare's long-term plan to transition from fee-for-service to fee-for-value and incentivize improvements in quality and reductions in cost. And that is the direction that I think everybody wants to take healthcare, and wants to provide the best care and wants to be competitive in their markets. And, really deliver excellent service to seniors and all patients. That said, obviously right now, probably everyone's just glued to their screens and, just trying to get through the week. I know for me, last week felt like a lifetime, and it continues. So, I think it's sort of hard to hold both those things at once, and I understand that. And I just want to say that, I'm here to help you kind of reorient toward your long-term plans and in making this transition, because it is happening all the while that these short-term things are happening. And I also want to send out a lot of support and blessings to everyone on this call who's in the healthcare industry, providers and administrators, because we need to be so strong right now and really walk in a beautiful way and create a beautiful world going forward. So sending out many blessings to you all. All right, let's take a look at this polling question, Emily. Last one.
All right, our final polling question. Is your organization ready to apply to the direct contracting model? And your options are A, we've already submitted an application. B, we are seriously considering and preparing our application. C, we are still evaluating the DC model and other alternative payment model options. D, we will probably not participate in DC model or any alternative payment model next year. Or E, not applicable or we're not sure. And once you have completed all CPE requirements, you will be able to download a PDF of your CPE certificate from the CPE progress window to the right of the slide view. All right, let's go ahead and take a look at what everyone has to say. Back to you.
Okay, thanks so much. Sorry, I'm starting to look at the Q&A box, but yes. Okay, so still evaluating, yeah, and that makes sense. I mean, this is a relatively new model, and as I mentioned, there's options. So understand that you're all still evaluating, and I hope that you'll reach out to me if you would like any support in your evaluation or have any questions. And so with that, I'll put my contact info up here. We have a couple minutes left. Emily, did you see any questions that we could get to right now?
Sure. Let's see here. If we're not ready to apply right now, will there be future opportunities?
So I think that there will be, but I can't say for certain. So, Medicare has only stated their application timeline with the due date of May 1st for program year 2021 start date. So we don't know if there will be future years. I suspect that there will be, especially because they proposed this geographic model but didn't release it yet. So I think there will at least be an opportunity to apply to that portion of the model in the future. Any others?
Let's see. We do have a lot of questions, and we probably won't have time for all of them, but I think we can squeeze in one more, maybe two. Can you change model selection from year to year?
So the answer is yes. So if you start in the model in the professional, which is where you're in 50% risk, you can move up to global, which is the 100% risk. However, if you start in global, you can't move back down to professional. So, so the answer is yes, but.
Great, thank you.
Okay, maybe
let's do
maybe one more question.
One more. What is submitted for the application?
Well, I honestly couldn't provide a fully comprehensive list on this call, but it is things along the lines of a list of who your governing body is, certainly information about what the DCE entity is, the tax ID number, the name, the incorporation date, the governing body and an org chart, the key leadership such as the executive director and medical director, and then the list of providers who will be in the DCE, and you would provide a preliminary list by that May 1st deadline and finalize it by the end of September. because they use that list, those NPIs, to align the beneficiaries and set your benchmark. And then there are quite a few narratives, narratives about how you're providing the, IT and care coordination and patient engagement infrastructure and delivering value-based care. So basically, Medicare kind of wants to know why you want to be in the program and what you're going to do when you're in the program and how you would manage risk. And you would need to have a repayment mechanism in place too, much like in other models with risk, so that they know that Medicare has a way to kind of recoup dollars if you have shared losses. Oh my gosh, we're at the top of the hour. Thank you so much, everyone, for joining us today, and I'll reach out if I received a question from you.
All right. As Georgia mentioned, we are right at the top of the hour. If you have other questions you think of, you may reach out to Georgia directly. Her contact information is here on the screen. Thank you, Georgia, for a great presentation today. We appreciate you calling in while you're snowed in, and we're happy that everything went well. As a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet found in the slide deck and handouts window to the right of the slide view. If you participated as an individual and met all certification requirements, your certificate is available to download now in the CPE progress window. I'll keep the webcast console open for a few minutes to give you time to download your CPE certificates. A copy will be emailed within 3 weeks should you have any difficulty downloading it now. Here is a link to an online survey where you can provide feedback for today's presentation. Please take a moment to complete this survey, as your feedback is very important to us. Thank you for joining us, and we hope you'll join us again next time.